So let me start with introductions real quick. We're not going to go through everybody's bio here. Aneesh Chopra, right at the end. You probably all know him here. He's the president of CareJourney, an open data intelligence service launched by his own incubator, right? By your own, what you call your hatchery. And he's, of course, the former chief technology officer for the US. And we have Julia. Julia is a director of the Clinical Informatics and Improvement Research Center at UCSF, and she is an expert on policy management issues related to the use of IT in healthcare, particularly on the adoption of healthcare cost and quality. And we have Jess Kahn, who is a senior expert at the McKinsey and Company and specializing in Medicare and social services programs, and recently named one of the foremost influential women in healthcare IT by HIMSS for 2018, and used to lead data systems at Medicare at Medicaid for CMS. We seem to be missing some people here. I know we're getting mic'd up here. That is Lucia Savage. Wave to the crowd. She's the Chief Privacy and Regulatory Officer for Omada Health, and she is a recognized thought leader on using HIPAA to advance digital health while protecting privacy. And we have Dennis Lund, who is, of course, many of you know, he is the interim president and CEO of the Lucile Packard Children's Hospital, and a well-known surgeon specializing in, well, formerly trauma transplant, and now it's pretty much everything, right? All right. So I have to say that we had a pre-call. Sure. We had a pre-call, and it was feisty, and people were interrupting, and they were cutting each other off. And Aneesh in particular was like, hey, can I just say one nice point about this? And then he'd like come and jump on everything. So what I'm hoping is we do not lose that. I am fantasizing that you will all interrupt each other, that you'll cut each other off, because it's late in the afternoon, or early in the afternoon, but late in the morning, and we have to get everybody jumping up here. The other part of this is that we've had a lot of this conversation for the whole day, and we know what the big issues are. And so what I'd love you all to do is interrupt each other or actually respond to some of the things that have been said here today. Lucia, I want to start with you because you were the latest to come up here on stage.
I knew you had a plan.
Yeah, exactly. No, but you mentioned something on the pre-call that I think was really interesting and I'd never actually thought of because I didn't think people could be passionate about EHRs. But you said, why don't you ask us why we're passionate about EHRs? And I thought, oh, that's a great idea. So why are you passionate?
About 12 years ago, right after Kaiser had kicked off its pre-high-tech EHR, my mother is a Kaiser patient. She was bipolar her whole life and also had COPD. And when she took steroids, they caused a manic episode. So very complicated pharmacology. She was taking lithium, and her PCP said, wow, your kidney function is bad. I'm going to switch you to an on-patent medication. This is during the donut hole. And I'm trying to explain to my family how to calculate when the donut hole, when you trip into it. And it was not a good drug for her. Sleepless, nausea, leg cramps, just everything about it was bad. And I said, you know, what did your psychiatrist? Well, a psychiatrist agrees with PCP. I'm like, have you seen a nephrologist? She said, what's that? I said, that's a kidney doctor. Let's get a referral to a kidney doctor. And we went to the kidney doctor, and he opened up the EHR, and there's like a 10-year history of her kidney results. He could pinpoint within seconds which ones were in hospital for other things and which ones weren't. And he said, yes, your kidneys are failing, but you're 80 years old. So who knows why they're failing? And by the way, they're not nearly as bad as you think they are because of all these other things I can see in your lab results. So put her back on the lithium, which she then took until she weaned herself off. So probably another friend of ours, same setup, did not get to the nephrologist, took the drugs that weren't very good for him, ended up suicidal, and let's just say he's alive, but it was not a very good result. And so when I look at that, I think, wow, the power of this tool to be able to get the right information to the right professional at the right time really changed this particular patient's life. And so that kind of drives my passion for it.
Anybody else have a passion story here on this list? Somebody, I know, Aneesh, you actually mentioned something that I thought was really striking in the call too. You talked about our big problem is a grammar problem. You said, you know, you actually repeated this many times. You said we keep confusing our nouns and our verbs. Tell us what you mean by that.
So I think the conversation we've had all morning has been EHR as a thing. And if you recall, when we funded the $40+ billion, or I guess 34, Don, you'll correct me on the math, but what we did was we made a conscious decision to describe them as a series of connected modules. In a sense, the notion of the verb, that there's information that's flowing from A to B. And so every conversation you had earlier where the EHR as a noun was described as a thing that needs to get better, but kind of missed the actual underpinning of this story, which is it's not a single thing, it's a collection of things that are connected. And as long as we have standards-based mechanisms for connecting, we can unleash a massive creativity economy around ways to make it better for doctors, to reduce burnout, better for Lucia's mom to have more coordinated care, and as Rishi was describing on the earlier panel, these care teams that are evolving in these business models who can actually assemble the information appropriate at the time. Today, we feel like we have to sort of pray at the altar of the EHR vendor to like make a release to their product to make it slightly better. And I think that that's a little bit like, what are you talking about? We have standards-based methods to exchange information. We should have the ease of simplifying our lives with downloading a third-party app that can plug right into the infrastructure and work, because the verbs, the mechanisms of moving information through the system, are standardized. So it's not the technology issue, it's the data standards opportunity that was enabling this new, hopefully a marketplace of components that we call collectively the EHR.
So I heard a few adjectives in there as well. So it was nouns, verbs, and adjectives.
Yes.
Julia, a lot of what we've heard about and what Aneesh just mentioned is fundamental to what you've just written about, which is, you know, we sort of rage against the problems raised by the EHR, and some of them are real, but a lot of what the EHR has revealed other kinds of problems with our systems management in healthcare.
Yes, absolutely. And I mean, I think I do get frustrated when so much attention and frustration is focused on the EHR, and then you say, well, is the root of the problem a technology one? And the answer is no. Well, then why are we trying to solve it as a technology problem? And I think if you look upstream, it is. I mean, when we've been talking about it in this room today, it's people, processes, incentives. And so to sort of continue to focus on the EHR as the problem and then by default the solution, we're missing the opportunity to really fix the key problems. And I think that that is where you know, we need to shift our conversation so that we can have long-lasting solutions.
Well, this is definitely going to be the first national symposium on EHR problems that isn't going to blame the EHR. That's my takeaway from today. But Jess, I mean, you also, part of your passion is let the computers do their job, right? So you want to liberate computer systems.
Well, I want to liberate the data that's within them. My main premise of this is whether it's clinical data or it's social determinants data or administrative data, a lot of the blocking has to do with people's lack of confidence in that data themselves. And this was part of the early resistance with adoption and sharing anyway, as people were afraid that the data would be incorrect. And what I would posit, and what we've seen it play out actually, is that the more eyes that are on data, the better it gets. And so when data resides in those silos together and isn't shared, then those problems just confound on top of each other. And so when you have broader data sharing between, say, care providers, between outpatient and inpatient, between community services, that's when those things get picked up. And that's where things get better. And so this continued siloing of data, whether it's in an EHR or in some state data warehouse, continues to perpetuate the issue.
So Dennis, how good is the data?
Well, I think there's a lot of very good data. The problem is how are we using that data to implement patient care? I mean, after all, the EHR ought to be about providing patient care, right? And it actually ought to be about providing patient care in real time, not you know, just some data warehouse that's out there. So going back to Lucia's example, if I'm a doctor and I'm writing a prescription for her mother, and that prescription conflicts with some of her other prescriptions and is likely to cause her to have renal failure, why doesn't the EHR automatically notify me that in real time? And we actually are now implementing those kinds of things in some of the pediatric work that we're doing, where if you're on nephrotoxic drugs, 2 nephrotoxic drugs, easy for me to say, and you add a third, the computer system lets you know. What it ought to do is actually send me a page and say, did you really want to add that third nephrotoxic drug? And so that, that data is out there. We still have the problem of what I call the 17-year rule, and that is it takes 17 years to get into practice what has been found to be medical truth. But in a time where medical knowledge is doubling faster and faster and faster, we actually need to use the EHR as a partner. And this is where the whole AI piece plays into it.
So the connection between doctors and cicadas, that's what I'm seeing here right now. Aneesh, you have talked about this. We're not playing the blame game here, of course. So let's blame CIOs.
Sure. I'm in.
Okay, great.
Let's go.
So are there any CIOs in the room before we start? Okay.
Yeah.
All right, not that many.
More than lawyers.
Three or four. Okay, but this is and you give the example of fire, and you say, very few CIOs actually said, hey, let me take control of the third-party apps that are coming into my hospital system, and see if I can make sense of it.
Well, here was the context that kind of teed off this part of the discussion. So if you go back in history, 2015, there was a vigorous policy debate about how we were going to allow consumers to assemble their health information by connecting an application of their choice to that EHR system. And Dennis, in this analogy, the patient who comes to you who has a community pediatrician who's on a different EHR might have a medications list in that system that may not be known to you for all the reasons of interop and so forth. So might the patient have an app that could allow that system to communicate? So we spent a lot of time kind of figuring out what was the data set. It's not the entire health record, it's a subset of the record. And then how might you connect it? You'll hear this expression, the FHIR API, because all the major EHR vendors voluntarily, I might add, agreed to use a common approach rather than a vendor-specific approach to meet the meaningful use rule. Don has all the statistics. Over half of the certified products today all voluntarily agreed to use this open standard. And by the way, Apple, and the punchline to your question, and today's the Worldwide Developer Congress. We're all on the Twitter to see what Apple's announcing on Apple Health today. Something awesome is coming, I would imagine. We'll find out. The point is, Apple chose not to add an Apple widget as a proprietary method to assembling the record. They said, we're going to build on this FHIR API, this industry-led consensus effort. Oh, my goodness. Someone here earlier in the day was from Epic on the thing. Epic is awesome. Cerner's awesome. Everyone's awesome. I like everybody. Just to give you an example, Epic is the one EHR vendor that publishes this. They made the upgrade to turn on this FHIR API free to their customer base and available in December of 2016. I started asking questions of CIOs. Will you turn it on? Have you turned it on? It's like literally 5 clicks. It's like you email Epic and say on. It's not like it was a multi-million-dollar project, complicated issues. And then I'll be like, oh, busy, other priorities, we'll get around to it, blah, blah, blah. And so the adoption rate, because Epic publishes every site that was live, very low. And the irony was I'd see a CIO who's like speaking on the future of AI, machine learning, and then their name's not on the list, they haven't turned it on yet, okay? So by the way, Apple announces they're embracing the FHIR API. And they announced the systems that went live in that, whatever, the first dozen or whatever it was. And all of a sudden, I start calling a bunch of CIO friends of mine, like, Aneesh, the board is yelling at us. We are not on the list. We have to be on the Apple list. So all of a sudden.
This is what the call was like, by the way.
Yeah. What's amazing.
Yeah, that's true. That's right.
What's amazing in this story was we've come from a compliance mindset.
Right.
Not a let's make this better for Lucia's mom mindset.
Right.
Nothing. No technical budget burden got in the way.
No.
But I have to jump in there because I was there when we wrote the rule. So first of all, what you all have to know is very deliberate. We very deliberately wrote the CMS rule and the ONC rule to sit on the bed of the patient's right to get their data.
Yes.
You all have that right. Your patients all have that right, and it's been around since 2000. It is not new. All we did was applied some digital facts. If you go back to your institutions and your lawyers are like, what is she talking about? I'm happy to get emails and tell them where to go look. But the second thing I would say is I was just a month ago talking to a room about this big full of people who manage the records rooms in your institutions. And I said, show of hands, how many of you are talking to your CIOs about what the FHIR API is? The only hand that went up in the room was the developer who works for the company that services the information rooms. It was really sad. And how many of the institutions are hugely capitalizing? The board is screaming about the Apple list, but they're not capitalizing, empowering computers to do what they do best, which is move things out of sets where they're not related, in the document rooms. Because for the profoundly ill people, it's more than just what's available in that Apple Health Kit. You need a lot more data to move to a lot more places. So yes, I'm glad the CIOs are hearing from their board, but I would like that noise to be a lot louder.
Yes.
So Kevin Ben, just a moment ago, he said something really interesting. I thought all of the panelists were fantastic. And he talked about the fact that, nothing really changed until they decided that in the Copernican era that the sun was the center of the universe. Well, they didn't decide that. I mean, the sun is the center of the universe, to the best of my knowledge. And, but the question is really getting back to the patient. So is the patient the center of the healthcare universe? Let's ask that, because this patient doesn't feel like she's the center of the healthcare universe.
See, I took something else out of that panel. I heard that things didn't move until people started assuming more risk.
Yeah.
That's what I heard. Did anybody else have that impression? When the incentives aligned, that they had to understand what was going on with those patients because now they own some of the risk, then they started asking questions about whether people have transportation. This drives me crazy, this question, because we've been answering this for 15 years. Speaking of AI, you don't need it. Just posit that if you are a low-income Medicaid beneficiary, transportation is an issue. And then ask them to prove the affirmative. Oh, and you can also posit that they do have access to a smartphone. Let's stop arguing about that as well. So I don't think that patients are still at the center of it. And I would actually say maybe pediatrics is the exception to that, but it always has been, digital or otherwise. So I would say it's still a policy and financing that is at the center of that. And I'm not talking about what makes people happy and what gets them into their careers and their jobs and the passion they bring. That's obviously patient-centered care. I'm talking about what makes the decisions for these huge shifts to change and for people to make these investments, largely because they have boards to scream at them. It comes when they are forced.
But it's funny. I think, go ahead, yeah.
Can I add something? So when I came in and I was reading my Harris poll, what I realized is that there's a corollary amount of data about what the patients and the caregivers really want. And the data has shown for about 10 years pretty consistently that between 80 and 90% of the patients already think that the physicians are moving the data for them, and they're upset, surprised, and frustrated when they have to make it happen themselves. 1. 2, that less than 10% of the population is really obsessively worried about their privacy in the healthcare system. Because of point 1, they expect the physicians to share with each other appropriately for that care. And so I think that when we think about whether the patient is at the center, there are a few assumptions within our institutions that we can challenge that might help us not just, we can rail on the regulators. I used to get wailed on. I'm a former regulator. But look at our own policies and procedures, and are we making it so much harder than it really needs to be so that we can free the physicians to do what we've spent all that money and all that time training them to do?
Yeah, I mean, it's interesting. I mean, I think of myself as a pretty educated consumer. I book my own travel. I, buy things on Amazon. Woohoo! But the one thing I don't do is I really don't control my health records. I actually, and I write about healthcare on a pretty consistent basis, and I don't control it. So I'm actually I'm not in the driver's seat. And should I blame myself for this?
No, I mean, I think the point is you have the power to do it if you want.
Yeah.
But the rules, the federal rules in the system are designed so that you don't have to. Cliff, if you got sick, we would want you to focus on following your doctor's instructions and getting better. We wouldn't want you to have to worry about the manila envelope or the red robe that's this thick full of stuff. And if you don't know Bray Patrick Lake, you can ask her for a picture of her medical record, and it's like 5 notebooks and 3 CDs. How many have a CD reader? Anyone have a CD reader at home? Yeah. So we want you to get better. We don't want you to be the librarian. You can be. And maybe you'll help us crack loose the interoperability rock because you'll be using the apps that we set up, but we don't want you to have to do it. At least that's what I think.
What also spurs it is, especially with the population shift growing where more people are living longer, it's the caregivers who are now paying attention to that. I don't have I don't mess around much with my own data, but I know all about where my mother's data is, and I know all about where my youngest child's data is, because both of them have interacted with the health system. So if this isn't a person issue for the individual now, you better believe it's going to be for your parents or your children or whoever, your spouse, whoever it is that you're caring for. So we have to think about ourselves in that context as well.
Cliff, if I may just take two quick things. Actually, Dennis, you should probably go first. I'll pick up on that back.
Well, two things. One is we are beginning to exchange records much more easily. We've now, since our Epic go live at Packard Children's Hospital, we've exchanged over 14 million records in all 50 states. One could argue.
With other Epic systems?
With other Epic systems. What
about with non-Epic?
Well, and that's a good question.
That's kind of the question.
It's a good question.
That answer? That's a big question.
But my second point is that there's another part of this, and that is about patients being able to own their own health records. And so I'm going to ask Natalie, sitting here in front row, what's been the biggest roadblock to implementing open notes? Providers. It's providers.
Yeah.
And I'm one myself.
We are totally blaming people. I'm just saying, right for the record, there's a lot of blame coming here.
But there still is this fundamental disconnect in the provider community about whose record it is anyway.
Right. Dennis, this is a good segue to the question. I was going to make a comment and then a recommendation. Comment. In the first version of Meaningful Use, stage 1, a requirement we added was that the consumer had the right to an electronic copy of their discharge notes within 3 days. The rule was 50% of the patients who requested get it, 72 hours, exactly right. So Dennis, there's no provider judgment in there, you get it. And Don will tell you the statistics, 93% of all hospitals comply with the order. Okay, so that's a happy story, with one massively embarrassing footnote. In the definition, we made the denominator in this metric the number of patients who requested it. And Don will tell you, including some of the major fancy names that are in this room today, 54% of all hospitals in the United States of America, obviously not Dennis because he's not Medicare, 54% of all patients, of all hospitals said, under penalty of perjury, I might add, that not a single patient requested it. This is 2000, forget APIs and Apple and whatnot. This is like
2014.
Email a PDF version of this to my Gmail account. That technology, okay? Since 2010, the rule, 11, 12 when they first rolled out. So majority, that's discharge planning offices, Dennis. That's not the physician blocking it. It's the discharge office not telling you you have this right. Point 1. Point 2, there was a previous panel discussion where it's not a technology issue, it's the incentives issue. I will concede all that's true, but we have a data standards problem. Let me clarify. When Lucia and I had this back and forth about the medical records office, when the government regulated the EHRs, we only took structured data. Do you smoke? What's your problem list? What's your meds list? And that limited amount of information is what we regulated, and that's what's feeding all these open APIs. All the other information, pathology reports, clinical notes, everything else, which is the bulk of the record, unregulated. So today, there's no common standard for the data that's in the rest of the record and moving around. So Mark Harrison made a beautiful comment about what I assume is the PHQ-9 survey, the behavioral health assessment that flagged an intervention that he just mentioned in your one idea for whatever. That's not an open data standard. So if the primary care doctor in Utah does the exact same thing as part of their annual wellness visit, and they store the exact same survey, that's not feeding the Intermountain algorithm to decide whether or not the person gets the intervention. Not happening. Forget interoperability. It's just, there's no mechanism that's not a standard. So Mark also said in the previous session, he signed a pledge to join with other health systems to help the VA. Because at the time, Secretary Shulkin put a stop on his EHR procurement and said, I want the whole record, not just this minimal limited data set. And I want not only the patient to get access, I want the doctors to have access, and I want the care teams who support them. So I want multiple access methods, and I want the entire record. So this group of providers, including Intermountain, God bless America, and I hope many, many of you, will join voluntarily to say, let's just get a group of people to agree, what does the PHQ-9 survey look like when we share it? So we have common standards for the entirety of the record. Don will love you for it because he's awesome. And I think we can make a lot of progress. So that's the gap between tech and data, that you can't just say, well, the tech will solve it. No, no, we got to do work. Once we get that work done, then we can apply the rules that Lucia said that says we all have the right to it to the consumer, and then we can make them.
But can I just bring two threads together? Because I think we've been talking about incentives and then standards, and I mean, they directly relate to each other, right? Because the harder it is to do it, the greater the incentives need to be to do it. And I think a lot of health systems are getting caught in between, where they say, we want to do this, but it's so complex and expensive that it's competing against everything else that our dollars need to go to. And so I think what we need to think about is, how can we make it easier to do it such that we don't need to ramp up the incentives to the same degree, because they directly trade off.
But here's the thing. So first of all, one could have a whole day on whether $40 billion was enough incentive or not, because that's definitely what you hear in DC, is that we spent $40 billion and this is all we had to show for it.
It was part of the Recovery Act, just to remind everybody that the purpose was not just to support the adoption of electronic health records, but also to support the economy. So
and it was a huge,
sure we're benchmarking it based on its intent, its congressional intent.
I work for a startup, but I would say definitely huge economic stimulus. But I want to go back to Aneesh's point about the 54 hospitals, 54% of hospitals, because this weekend I was at the American Society for Clinical Oncology talking about something similar, and I got a tweet about faxing being required. And I said, no, there is no law that requires that you fax. And the message from a different tweeter that came back to me was, I'm helping my mother with 9 physicians, and 8 out of 9 of them require me to fax their office. And my response was, I bet they are all meaningful users, and I bet they all have a portal, and I bet they all took incentive dollars. And why is that portal not working at HHS OIG, which is the fraud investigator? So we have an incentive problem, as Julia said. We have some technology we need to work on making better and more expansive. And we have, within the system, we have the human factors of people are used to their faxes. They're unfamiliar with the safety and security of APIs. We can have a whole conversation about that. There's all these pieces. It's a very complicated puzzle.
We're here in the heart of Silicon Valley, and I asked you, Aneesh, I said, we were talking about Apple getting 30 health systems to be able to provide a very easy to use access health record for anybody on their smartphone. And you said Apple did nothing. They did absolutely nothing. You said, all they did was they said, you guys have to have the same standard and, the technical requirements. And the reason why they were able to do it was, whereas Nobodyville app, I think was the word you used, couldn't do that, was because Apple's Apple. And the question is there anybody else like Apple out there? I thought the federal government was the Apple of
That's who made it possible.
In terms of the big gorilla. I mean, who's pushing
If you follow all of the former Fed wonky tweets,
yes,
you will note that we made that point, that there was quite a fabric laid upon which that announcement came.
Yeah, but to answer the question exactly where Jess is going, the reason I said they did nothing, I did not mean that they did nothing. They obviously built services at the back end, but there's no specific Apple software anybody had to deploy unique to Apple.
There's no BAA, there's no backdoor, no.
Yeah, and that's the other thing. Could you imagine making your patients sign a business associate agreement to get their data?
It's not necessary.
Ridiculous. Thank you, Lucia's right. So here's the point. What Apple's doing is a phenomenal public service.
Right.
They are laying the foundation, because once the systems turn on the Apple service, the marginal time and effort and cost to add it for a Nobodyville app is zero, virtually zero. And so the point I'm getting at is an advocate for the patient who can help bring the systems in line is critical, necessary, but not sufficient. CMS administrator, Seema Verma, did something wonderful. She said in March at the Health IT Summit, HIMSS, I'm not moving the deadline. Doctors and hospitals must be on a meaningful use. This is essentially the third stage. I'm getting wonky, but the technical edition, the 2015 edition that Don certifies, have to be on a certified platform in 2019. And the proposed rule for hospital reimbursement says no delays, we're doing it. So my point is Apple's one piece to get the system thinking in a different way because it kind of made news. But the undergirding is that the regulations mandate it. And so it was voluntary in December of 16 when Epic loaded out their software and people could have turned it on if they wanted to. But now it's mandated. So my sense is that you're going to see a huge adoption curve in the short run. But here's the more fundamental point. In my opinion, the voice that Apple represents is really a voice for any application that will help our family members make sense of the data. So it's not just about moving a bit from A to B, it's understanding context and everything else. So the bigger number to look for, Cliff, is the following. Over 400 app developers are in line to connect to the CMS Blue Button API, which is a related but different FHIR API. And that includes 23andMe, that includes a whole bunch of other Silicon Valley awesome people. And what that means is my parents both are on Medicare. They will have a marketplace of apps competing to help them make use of the Medicare claims data as one example. And once they start doing that, each and every one of those apps will come right knocking on Dennis's door at Stanford Children's, and he'll ask the staff, do we information block these people? Do we allow them in? And that's the conversation that's going to come. And either the health systems are going to wait for this marketplace to come at them, or they're going to embrace this and encourage it and see it integrated into the physician workflow. And that's going to be the separation between those who are getting it and driving it, or witnessing it and having it come to them. And that's, I think, the moment. Now, Dennis, do you want to react to this? How you want to drive this internally at Children's?
I'm all for it.
But I think it's also important to recognize, though, the fact that it had to be mandated, right? I mean, it means that it's not being demanded by the market, right? That we feel like we need to say in a regulatory framework to vendors, you must provide this, right? And I think that's the dynamic that we need to be revisiting, right?
But here's the irony.
It was only for Medicare also. I mean, I'm hoping, like you said, that that's cracking open the door.
It will.
Right, but the mandate isn't necessarily there for Medicaid and for all the rest of the commercial coverage.
Jess, we got work to do. We got to.
But I mean, we have job security, but I'm just saying. But like, I think there's an important lever that we keep coming back to, which is the balance between technology and innovation, and where government regulation has some power to spur it, or financial incentive.
Here's the quick irony. Take what Julia just said, take it to Rishi's comments, where he said, hey, we signed this advocate deal a decade ago, and it made the business case for us to stitch all these systems together. Now, let's do a forensic audit. Let's figure out exactly how much money Rishi spent stitching together non-standards-based data feeds, normalizing it, data warehousing, manipulating population health analytics. It ain't cheap. Now imagine he rebuilt that entire infrastructure in 2018 using the technical standards that undergird what you saw with this FHIR API. And even better, what Don is talking about with the population health use case, which is being developed right now. My humble opinion is that that is 90 to 95% cheaper when we move to standards-based. Because how much does Apple pay the hospitals to connect to the data? Zero. How much do the patients pay Apple to access the feature? Zero. How much do the hospitals pay their vendor to enable Apple? Zero, if they're on certified technology. So that's the question. It should be in their interest, Julia, and for some reason, it's not happening at scale.
So the name of this session is called Unleashing Data to Transform Healthcare. And I want to talk just a little bit riff on the last session with the population health. There was an interesting study in Cell last month. Some Columbia University researchers, they took 5.5 million anonymized EHRs, and they used an algorithm to connect them to presumed family members using the emergency contacts. And then what they did is they took another algorithm to see if they could suss out diseases that had a heritable nature, that there was some family connection in these diseases. And it's a really interesting study, you know, not much in terms of definitive discovery, but the idea was, you know, sinus infections apparently have a familial component, who knew? But what's interesting is if it brings up Judy Murphy's comment before about the fact that if we can connect EHRs to the other data systems, genomics, all of the other peripheral systems, data systems we have, imagine what we could unleash in terms of data. What's stopping us from doing this?
So I want to take that directly back to what Rishi said. So what's stopping us from doing that is we protect the data to prevent bad things from happening to the people who are in the data. So the privacy people read that study and went, oh my God, that is so creepy. Don't be creepy, right? We protect substance use disorder data because we discriminate against drug addicts. We protect mental health data especially because we discriminate discriminate against people who are mentally ill. We protect other characteristics that are mutable or health-oriented because we've chosen to protect the data instead of protecting the people. And so to Rishi's comment, if we are really going to learn from this data, we have to figure out how to strike a different balance. And in some, probably many of the people in the room read that New York Times article from the magazine 2 weeks ago, where the physician's practice is sitting and talking with the patient, right? That builds the trust so that the patient will take advantage of the system that's in place, which is the data should be used for health, and it shouldn't be used to make bad stuff happen to you in your job, in your retail, in your credit rating, in your mortgage, with your marriage, with your children, whatever it is, right? And so that is actually how we unleash the data, is by rebuilding the trust of the people whose data that is. I would not want somebody to make genomic deductions about my family because of my cell phone or my Facebook posts or any of that. By the way, Facebook thinks I'm African American, so they totally need to work on their algorithms.
So, I mean, bringing up Facebook, Julia, I mean, one of the things we've learned is what happens when there is a blow to trust in the companies that hold our data. How much has this hurt this sense of the value of EHRs?
I mean, I don't think we've had that blow to trust. I think we are constantly anticipating it and then acting as if that's going to happen. And I mean, I completely agree with Lucia. I just think our framing around this has been all wrong. And what we need to see is the risk of not sharing the data, not connecting the data, instead of having this hypothetical fear of the bad things that will happen when we do.
So,
I was going to say, it's interesting news to watch. So, eClinicalWorks got in trouble. They weren't interoperating, blah, blah, blah. There's a civil lawsuit against eClinicalWorks for $1 billion because they didn't exchange data. And a guy has articulated a class saying, you didn't exchange about me, and I had all these things happen because my data wasn't available at the next place in the system. And I've been waiting for this lawsuit for many years, and I think eventually, in fact, the medical standard of care will be to exchange. To Julia's point, we're not there yet. But if the data is there waiting for you and you could get it easily without special effort, and you don't, just think about that for a second.
So, we are so used. I love the example before. I think it was Taylor that talked about the fact that, pilots trust their computer systems and they're up there. I was talking with Lloyd before, Dean Miner, and he said that, ATM machines around the world, what do you trust more than, what sort of obligation is greater in terms of trust than protecting your bank account, for a lot of people. And so internationally, we have a system of protocols, of standards in which any bank, any ATM machine in the world, you can go to and get your, with a 4-digit or 6-digit PIN code. I mean, why is it so, what is holding back on the standard side?
So I think Julia's right that we've had a compliance and not a strategy approach to privacy and security. I won't bore you with the details. When
Please.
ONC launched the open API, the first thing we heard was it's not private and it's not secure. And so we did a 9-month project to explain through public meetings and white papers about, in fact, it was just as secure as all the other APIs you are all using right now to tweet. Or whatever you're doing instead of listening to us. It's all the same technology. And so the technology for that is out there. And we cannot stop bad guys. And to your point, in Guatemala, you will never want to use an ATM because they're all compromised. At least that's what I hear. So it kind of depends on the country.
So leaving Venezuela, Guatemala out or wherever
they're bad guys.
Let's just,
We can't stop the bad guys, but we don't stop driving just because we might get in an accident.
Well, let me a friendly amendment on this, just if I may. Username and password access to portals where you can pull in your medical records are far worse, security-wise, than an API. Let me just clarify this. This is a weird example where modernizing makes us more secure, not less. And let me clarify. By the way, health is not a vacuum. We did open API work in energy, financial services, by the way, all regulated. So in California, we're in California, Northern California, PG&E installed all those smart meters. You have today in Northern California the ability to connect a solar panel maker's app to your smart meter in the same technical approach that we're talking about that allowed that Apple Health to work. It's basically OAuth internet standard. Here's the issue. When we opened up the most popular government data set around these topics, it was the IRS GET transcript. We allowed every American to download 3 years of their tax filing history in a machine-readable format. 23 million Americans logged in and downloaded the transcript. But Cliff, a good chunk of them had their usernames and passwords compromised by shady people. So to the IRS, they came in right through the front door. But in reality, they were stolen credentials. And because there's no, the systems were not upgraded in terms of the API, there's no way of knowing what was the machine that was logging in. What the APIs do is you register, the consumer is authorizing a machine to talk to your EHR. So if I authorize the machine built by IBM that Paul made awesome, and it's working from a server farm in North Carolina, and then one day it switches to a server farm from China, the machine, the folks at Dennis's shop would automatically know to cut off access because they noticed an anomaly. By the way, this is how global internet APIs work. So modernizing is critical for the security debate. And whatever reason, we keep getting stuck and we can't. So in my humble opinion, the opportunity in front of us right now is to basically say the fundamental principle. And this is my final comment, I'll let you go. I think we're in a transition like the pension plans to 401ks, where I'm democratizing. I may not want to log into my patient portal and look at my statistics because whatever, what does it mean to me? But I would love to authorize a 401k like what we're calling a health information fiduciary that can store all of my information and help provide me the decision support to navigate through the delivery system. I think that future is coming. That's not Apple or Google or whatever. That could be a new Fidelity. I don't know who it is, Walmart, whatever. Someone is going to help construct that. And the foundation is being laid now, Cliff, that that's possible. And I want to just see that we continue to build on that progress.
Okay, we got 2 minutes left. I want to go through each of you. And since I want to have you both all think about 3 words, disruption. So 10 years ago, the continuous glucose monitor was invented. You have the smartphone invented. You connect the two, and suddenly you actually change lives. Tell me what you would connect to EHR. What new in your hatchery, Aneesh? What are we looking for to really change lives as briefly as you can? And let's go through each one of you.
Start with Julia.
Okay, Julia.
Okay. So I would say the life that I care about, my social life, my family, my friends. I mean, if you're going to change my behavior, I mean, that's what you need to get to. And so I think you need to connect my health data to my life. And that's, those are the people who I care about, whose opinions are going to actually result in my changing something.
Great. Jess?
So I think the reason we're one of the sickest countries in the world actually doesn't have to do with the lack of a widget here and a wonk there. I actually think it's because of lifestyle. And so the social determinant issues that Rishi summarized so well in the end. And so I would bring that in, and not as a nice to have, not as an ancillary, not as something you have to do a study to find out. But if you're my mom who has cancer and lives in a rural area and you're going to prescribe her a daily regimen of chemo and you didn't ever ask where she lives, which is 100 miles away each way, then shame on you for your oncology practice.
Mm-hmm. Great. Jess?
I think it's a combination of easily acquired caregiver credentials so the caregivers can communicate with the providers, and the universal CAMP medical record form app.
Oh, yeah.
Right? Because my kids are now grown, but there was a time when it was 24 pieces of paper, all with the same information, and the boxes in different places every summer. So if you really want to move the needle, the really sick people need a lot, but a lot of people need a little, and that's that universal CAMP app.
Dennis?
I'm going to go back to what Julia suggested, and that is connect my life to my healthcare record, but do it in such a way that I have a basic key that I can go into any healthcare provider anywhere in the United States or in the world for that matter, and just with that key, they know all about me and my health.
And with that, I want to thank my terrific panel. Thank you all. Fantastic.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.